Hi, Dr. Agarwal. Um, you are my hero. You're in New Zealand right now, doing OBGYN over there. Uh, but you've been in practice for decades, and I am so excited that you are also interested in hormones. Hormones
Yes,
as well.
love hormone replacement therapy, love birth control, love chatting about hormones. Absolutely. Yes, I graduated from residency in 2012, became board certified in 2014, and have been practicing since then, both private practice, academic medicine, and most recently moved to New Zealand to get a change of pace and have been working out here for the last 6 months.
Wonderful. So I just entered this whole domain of BHRT about, I want to say, 6 months ago. And I am very interested in hearing your views on the WHI study.
Sure. The WHI study was done in the early 2000s, and what it was doing was looking at the safety of hormone replacement therapy. Traditionally, hormone replacement therapy had been used pretty freely until that time. The WHI study was unfortunately not a great study that was conducted, but the repercussions from it have lasted until really about a few years ago. What the WHI study did was it looked at different subsets of women and their response to hormone replacement therapy, especially the risks and the adverse events that happened. One of the big adverse events that they looked at was heart attack and stroke. The thing that's important to remember about the WHI study is they selected women that were in their late 50s and early 60s as one of their arms to start hormone replacement therapy. What we know is that the plaques in our arteries, those are what break off to cause heart attacks and strokes. The plaques in our arteries are stabilized by estrogen. When we go through menopause and that estrogen gets slowly depleted, those plaques get used to living in an estrogen deficient environment. They get used to that. Then, if you throw estrogen on top of that environment, those plaques destabilize, and that's how you get heart attacks and strokes. This should be a seamless transition from when your estrogen is naturally depleting to us starting hormone replacement therapy so those plaques don't have a chance to destabilize. We don't start hormone replacement therapy in women that are 10 years outside of their menopause. That wouldn't be considered a safe metric. Our aim as physicians is to, again, be seamless in that transition so that our plaque in our arteries are used to estrogen the entire time.
So, in your experience, or from your understanding, would there be a difference between oral and topical hormone replacement therapy in terms
Yeah.
of benefits?
Yes, absolutely. So the word that I'm going to use here is thrombophilic. Thrombophilic means causing, again, heart attack, strokes, and pulmonary embolisms or blood clots in the legs. Um, Oral estrogen or oral hormone replacement therapy has been associated with the highest thrombophilic risks versus topical estrogen. The gels or the mostly the gels, estrogel, and that sort of thing, have been the lowest risk when it comes to blood clots. Every woman who's considering HRT should start with topical first to see if that gives them the relief that they need. In terms of the absorption, those are pretty comparable. And so, whether you're taking the pill or whether you're using the topical estrogen, it should be absorbed at the same level.
What about synthetic versus bioidentical progesterone?
So, this is actually where you probably will know a little bit more than me because in my space, we use mostly synthetic progestins. We don't do a lot of bioidenticals. I guess what I should say is I don't make a big distinction between the two. I'm going to practice more so whatever the insurance covers, and I'm going to try to go. So that's probably something that you're more comfortable discussing.
So, from what I have understood, the arm of the progestin that was done with the WHI study, there was a slightly higher risk of breast cancer, and it was pretty much related to the synthetic. And synthetic progestin has been, documented in the literature to cause slightly higher risk of. It's not a ridiculously high risk, but slightly higher risk. So from what I have been practicing, I've been giving the micronized version of
Sure.
bioidentical progesterone.
Sure,
And uh, I see a dramatic difference in a lot of women just with progesterone, especially if they're just entering their perimenopausal situations, and they're
sure.
still taking a fair amount of estrogen and they're estrogen dominant.
Sure. Yeah. No, progestin is a wonderful hormone. It definitely helps with sleep. That's why we recommend that a lot of women take it at night. It can help with hot flashes as well. It is definitely something to be considered if you want to avoid estrogen for any reason. In terms of the breast cancer risk, my understanding in the study was that the women already had breast cancer present, and the hormone made it more aggressive or progress quicker. So, definitely important to make sure that you're continuing to get breast screening done. So, mammograms, ultrasounds if you have dense breasts or a strong family history. Of course, if a woman has had a history of breast cancer, they would not be a candidate for HRT, whether synthetic or bioidentical.
I agree with you. So that's why that individualized approach comes in.
Totally.
Because, like you said, not every woman is going to need hormones or may not tolerate it.
Right. This is what's so important. And it's so great that we're now seeing a lot of people, like you, doing wellness centered care. This is a very in-depth conversation that needs to happen between you and your physician or you and your practitioner. We need to talk to you about your lifestyle, about the things that you're doing to help you sleep, about your phone usage, just generalized stress in your environment or your household. These are all things, also lifestyle managements and modifications that can help with menopausal symptoms. We sort of talked about progestins and sleep. Sleep is a big one that gets affected as we go through menopause. It's very hard to get a good night of sleep. One of the stories that I like to tell is I had a woman who was like, I have such a hard time sleeping, and I spent a few more minutes talking to her. She was a flight attendant and she was using wine every night to help her go to sleep. Now you have somebody who has absolutely no routine, their circadian rhythm is all thrown off, and you're using a notoriously bad sleep aid to help you sleep. HRT is not going to help, right? And so these sorts of things are also a nice way to support women. So if the hormone replacement therapy either isn't working for them or it's not a good option, they do know that there are other modalities available to help them get some of the results that they want.
And I think this is such an important part that you're touching on, because I see women in their late 40s, 50s, when they go through menopause, their lifestyle is awful. I mean, you and I went through residency, and
Yeah,
how much night shift caused us all that agony, and what the cortisol level, what it did to the cortisol level. And then
totally.
you talk about thyroid health on the top of that. And then, of course, your eating habits are not the greatest, because once you're
Right.
not feeling well, you're not going to eat well, and then you're not going to detox very well.
Right.
And then, of course, if you don't have energy, how are you going to move? And
Absolutely.
so that is why I think this whole comprehensive and individualized approach comes in.
I could not agree more. It's so unfortunate that women in general, and this is a gross generalization, but does seem to hold true for all demographics, all cultures and races. But women in general don't put a lot of energy to themselves until their kids are out of the house, or they're usually in their 50s, and at that point you've created so many bad or poor habits that you really have to relearn a lot of these things. Women when we're in our 50s, we lose a lot of our muscle mass. And so people think, a lot of us are very programmed to think restrictive dieting is the way to do it. And that's not going to work in menopause. You're going to be weak, you're going to have poor muscle mass, your bones are going to suffer. We need to focus on other things in our diet to make sure that we're getting what we need. It's a big shift in mentality, and hopefully with the support of both your normal support system but also your healthcare team, you can make some of those small shifts before menopause hits you like a ton of bricks in your 50s.
So one of the biggest things that I've learned in my training is never put hormones in a bad gut. So if you have a bad gut and you're not detoxing very well, what kind of
Absolutely.
metabolites are you going to produce? So
Absolutely.
my mantra is clean, detox first, and
Yep.
then put hormones. So I really like that approach.
Yeah, I can tell you my own personal story. Like I have always been iron deficient and I could not figure out why. And my hemoglobin was always fine. So just, for the people that might not know, there's an association between our iron levels and our hemoglobin. And a lot of people who are iron deficient are also anemic. Anyway, so I just couldn't figure out why my iron was always low. Turns out I have a gluten issue, and gluten sensitivity made me have a leaky gut. And now all of a sudden, my my iron's not getting absorbed. I'm feeling really bad. I'm taking naps every day, and I just had no energy. Within 2 weeks, my energy levels were so different. My gut felt so different. TMI, but my just the bathroom wasn't a struggle as much as it used to be. And within a year, without doing anything else different, my iron level doubled. So it's so important to ask those questions. What are you eating every day? And again, a lot of women, especially those of us that grew up in the 90s, were very restrictive with our diet, and that is not doing us any favors.
Totally agree with you. Um, so if a woman were to have bioidentical replacement therapy, what could be the potential risks to her?
Sure. So, first and foremost, I always like to manage people's expectations. And I'm going to say, you're not going to feel like you did in your 20s. Like, we hope we can get you some relief, and we want you to have a better quality of life. But we can't expect that this is going to be the perfect fix, especially like we talked about, if you don't do some of that lifestyle modification as well. More serious risks, there is still a risk of increasing your blood pressure. There's a risk of migraines. There's a risk of heart attack, stroke, and again, pulmonary embolisms and blood clots in your legs and your lungs. So these are definitely things that women need to be counseled about, because these are very real risks, even in a low risk population with, that you think is a great candidate for bioidenticals or HRT, still need to be counseled about all of the things that can happen. I always say, I'm working with training doctors now, and I always say to them, medicine is not benign and intervention is not benign. And everybody does need to understand that there is a risk benefit ratio with all of the things that we suggest.
I think you have hit the nail on the head. Individualized and comprehensive approach is what is going to decrease your side effects of bioidentical hormone replacement therapy. So if you were to take a scenario, um, what do you think would be the advantages of bioidentical replacement hormone therapy?
Sure, sure. So, as first of all, women are entering the corporate world and staying there for a lot longer now. And if you're sitting in a boardroom and you're dealing with brain fog, that's going to be really challenging. Also, if you're sitting in a meeting or whatever the case may be, and your temperature is not being able to be regulated, we can always think about the women who were like fanning themselves when we were in school or whatever the case was. These things are very distracting to a woman's quality of life. We already touched a little bit on sleep hygiene. We know the importance of sleep. We know how good that is for overall, cognitive preservation and those sorts of things. But yeah, more serious things. If we can avoid the number of osteoporotic fractures that we're seeing in women in their 60s and 70s, heart attack, of course, women in their 50s are one of the biggest risk factor groups for heart attack. So hoping to minimize some of those things would be wonderful. Yeah, osteoporosis, heart disease, and then of course, like we talked about, strokes and pulmonary embolisms also could be a nice, strokes, I should say, would be hopefully reduced if we get more women appropriately on hormone replacement therapy.
So I just want to add something to that. I always tell women, menopause is freeing. You don't have periods
Yeah.
anymore. Why not make it a graceful journey?
I love that. Absolutely. This can be very graceful. This transition can be very seamless. Absolutely love that. Love that.
Thank you so much, Dr. Agarwal.
No, anytime. Love chatting with you.
Yeah.